Hi, and welcome to the Focus on Eye Health Expert Series. I'm Jeff Todd, President and CEO at Prevent Blindness. Joining me today as we talk about Stargardt disease is Dr. Elias Trabulsi, head of the Department of Pediatric Ophthalmology and director of the Center for Genetic Eye Disease at Cleveland Clinic's Cole Eye Institute. Welcome, Dr. Trabulsi.
Thank you, Jeff. Good morning.
So, before we dive into Stargardt's, the term inherited retinal disease or IRD encompasses a lot of conditions. Can you start out by explaining a bit how IRDs might differ from other common eye conditions we're aware of, such as glaucoma, diabetic related eye disease, cataract?
Certainly, this terminology has come into vogue the last decade or two. Um, Before that, we would call them retinal dystrophies, and we still refer to them as retinal dystrophies. And the term dystrophy implies that these are genetically determined conditions, predominantly genetically determined conditions. In some of these conditions, there may be some environmental roles, but what makes one have them is carrying mutations in one gene. Usually, and that's what we refer to as monogenic disorders. One gene does not work well, you develop the disease, as opposed to some of the common diseases like ocular misalignment, strabismus, or macular degeneration, where there may be some genetic determinants, but the exact genetic defect is not known, and where there's a multitude of other factors that may be in play. Uh, some of these eye diseases can be familial, so we know that there's a genetic determinant, but we have not been able to determine what the exact gene is that causes them, or the majority of them. Now, there are certain genetic diseases that cause strabismus, for example, or macular degeneration that are monogenic, where only one gene defect results in that phenotype. And I may be using this term later. And what we mean by phenotype is what we find in the patient, what the patient's signs include on examination. For example, we'll be talking about Stargardt disease today. And in Stargardt disease, when we look at somebody's retina, there are certain things, certain changes in the retina that the ophthalmologist would be able to see that point in the direction of this being Stargardt disease. So that's the phenotype of Stargardt disease. And, when it starts and how it starts and how it changes, that all is also a component of the phenotype.
So let's dive into Stargardt disease a bit. What is it and how is it diagnosed?
Stargardt disease, I have to say, is uh, according to many studies that have looked at thousands of patients with inherited retinal disorders, is the most common of all of them. And probably about 20% of patients with IRDs, and I will use that terminology going forward in this talk, have Stargardt disease. And it has a wide range of clinical expression, so we can find it and diagnose it in children, young adults, and even older adults. And one may not know that they are going to develop Stargardt disease until adulthood or late adulthood. The more severe, if you will, or the earlier diagnosed cases can be found in children as young as 5 or 6 or 7 years of age. And the changes in the back of the eye are also extremely variable. Uh, you can have whitish, yellowish deposits under the retina that are a reflection of the disease that's going on, and you can have atrophy or thinning of layers in the retina, and depending on what tests are done, there are some recently introduced imaging modalities that have been introduced in the last couple of decades that will show some uh, specific findings that would also point in the direction of this condition. At the end of the day, an accurate diagnosis of Stargardt disease is made by genetic testing because the great majority of patients have mutations, or now we call them sequence variants, to utilize the appropriate term, sequence variants in a gene called ABCA4. So those constitute probably more than 95% of patients who clinically appear to have Stargardt disease. And there are a couple of other genes that can cause this clinical picture. But by definition, when we say Stargardt disease, we are talking about patients who have sequence variants in ABCA4.
So, what are some of the symptoms, maybe early on, of Stargardt disease?
The symptoms depend to some extent on the age of onset. Let's start with children because those are the ones who classically are initially missed as having Stargardt disease. And they present with loss of vision, loss of central vision. So they're unable to read, they're unable to see the chart, the vision chart at a distance. And sometimes, because the disorder had started so early, there are still no visible changes in the back of the eye. So they go get examined, and the optometrist or the ophthalmologist who sees them because they failed the vision screening at school or at the pediatrician, it does not see anything inside. So it it's unfortunate, but it's real that some of these children are going to be either accused of faking their vision loss, or maybe not, but then the eye doctor is going to say, I don't know why they've lost their vision. And then they start getting other tests that might take them along, getting an MRI of their brain, or suspecting an optic nerve problem rather than a retina problem. As things progress, there may be then some changes in the back of the eye, and then the diagnosis becomes more evident. Of course, if you're an experienced uh, ophthalmologist and optometrist, you will pick up on that, and you will say, oh, you know what, that can be or maybe Stargardt disease, and we're still not seeing anything. And then there are other tests that could be done that focus on imaging of the back of the eye that will lead you to say, oh, that's probably Stargardt disease. How are we going to prove it? We get the genetic test, and we I don't know if we're going to talk about genetic testing later, but we don't get it in a vacuum. We get it with the help and support of somebody who knows about genetics, either a genetic counselor or an ophthalmic geneticist. And fortunately, we have more and more people who are interested in genetics and who know about it. And then the diagnosis could be uh, proven. So at the end of the day, and now in 2024, we know we can diagnose Stargardt disease accurately using genetic testing in the majority of patients.
So you touched on this a little bit already, but in your experience, could you talk a little bit about the, particular ages of onset,
Yes,
um, and maybe are any more prevalent than the others? And also, what is the general pathway of vision loss, or does it vary across patients?
very good questions. And it's this disease and this gene are particular in that depending on what type of mutation or sequence variation there is in the gene, the disorder may start earlier or later and may run an accelerated and severe course of vision loss or a milder one. as a general rule, and there are always exceptions as you imagine in medicine, the earlier the onset of the disease, the lower the eventual visual acuity is going to be. So the more severe, if you will. So in general, unfortunately, if we pick it up in the first decade of life, and that accounts for about maybe 5%, 5 to 10% of cases, uh, we, those children are going to end up losing much more vision than patients who have their onset in adulthood. And also they have or they carry the more deleterious types of sequence variations, the ones that affect that molecule, the ABCA4 molecule, more. There are patients who start out with other kinds of symptoms, including um, changes in color vision or dark adaptation, with night blindness and so on, and have their onset later in life. Those tend to have less vision, eventual vision loss, and will keep some vision either indefinitely or very late in their life. So there is no general rule of where vision is going to end up in patients with Stargardt disease, but these are all factors that influence the clinical course of the disorder. And there are other factors also, other findings on exam, on some of the imaging studies that we do on the ERG, for example, the electroretinogram. We know that patients who have early electroretinographic changes or decrease will probably end up losing more vision than those who don't. Those who have certain findings on autofluorescence, which is another test, also of a certain kind, will have more or less or be protective of the retina as opposed to others. So we can have an idea. And when we talk to patients, we can, if they if and when they ask, we can give them some clues as to what to expect, but we cannot be absolutely certain of where it's going to go. Uh, these are generally the questions that any patient with an IRD is going to ask you. What's going to happen to me? Am I going to go blind? Uh, where am I going to be in 5 years? Where am I going to be in 10 years? What am I going to be able to do? How do I organize my life? And do I learn Braille? I tell you that just the concept of what blindness is, and you probably know it more than a lot of people, is so variable. In people's minds, when they say you're going to go blind, they imagine they're not going to see anything. Everything's going to be black, nothing. Uh, for others, blindness is a relative loss, and even if they lose a little bit of their central vision, that's very distraughting to them. Others, they can manage quite well, and they're not that much affected if they can't see small print or small things, and they have good side vision, and they manage to do a lot of that what they want to do, and they're very successful. So Stargardt disease has this full range of effects on vision and life, all the way from being very, very bad in some patients and others where it's milder with a different set of signs and symptoms. It in a way it's the great mimicker in inherited retinal diseases. It could present with a variety of signs and symptoms, but we always have it in the back of our mind as a possible diagnosis. And once we do the genetic testing, that's really what seals it.
Yeah, your comment about kind of the definition of blindness is one that just struck me recently. I was having a conversation with a mother of a young man who's losing his sight, and he's struggled with some mental health challenges, and a lot of it she shared is around understanding what blindness means.
Yes.
And not fully understanding, the wide range of where those vision challenges could lead.
There is a big gap and a lot of deficiency in mental health support for patients who are struggling with loss of vision. I see it in my clinic. Um, we have, we're fortunate uh, here at Cole that we have access to superb low vision facilities at the Cleveland Sight Center, which is just across the street. And we have a representative inside our institute. So we channel patients to that. But those who are struggling uh, psychologically with their vision loss are harder to help, and they do need help. And I have conversations with them whenever I can, but I don't know what to do for them myself.
We recently had a task force to address that intersection of mental health and vision loss, and have some information on our website. And we're about to launch some more. I believe May is Mental Health Awareness Month, and so we're going to do some work around that as well.
I'll make sure to look it up.
Yeah, I'll be sure to send some of that to you. So are there any current treatments or therapies that can help patients with Stargardt disease?
Uh, there are no effective treatments that have been um, launched. Let's put it this way. The good news is because it's a common problem and because there's some overlap between Stargardt disease and age-related macular degeneration in at least a part of the eye that they affect, there've been a lot of interest in trying to find cures and even if it's not a cure, at least medications that would help slow it down. But we don't have anything yet in clinic. There's nothing I can prescribe to a patient today and tell them, I want you to take this pill, or I want to refer you for this gene therapy procedure so that we can stop the progression of your disease or slow it down. But there's a lot going on, and if anybody is interested to learn more about it, what I refer my patients to is a website called clinicaltrials.gov, clinical trials, one word, .gov, and they can just type in Stargardt in the search box, and it will pull up. Uh, I think the last I checked, there were more than 40 different studies. Some have been completed, a couple have been interrupted or stopped, and there's some that are ongoing, and they they include natural history studies. So I want to warn the the people who are listening here, when you look at a study, you want to make sure if it or you want to check if it's a treatment study or if it's a natural history study. They're all important because we want to know how a disease progresses and the timeline of it, so that if a treatment is given or is tried, is it affecting uh, the the natural history of that disease positively, so that it's worth taking, it's worth doing. And many of the studies listed on the website are treatment trials, but some of them are just observation studies, and they include some medications uh, with varying mechanisms of action. Some work by reducing the load of toxic byproducts in the retina. Others facilitate, um, you know, the prevent or are thought to prevent. And some of them have shown some efficacy in preliminary studies, but all treatment trials have to go through phases, phase 1 and 2 to check they're not toxic, and then phase 3 to see that they are effective. And even then, they still would have to go to the FDA, who would look at a bunch of different things and then approve them or not approve them for treatment. The questions I get from my patients, okay, how about gene therapy? We don't have gene therapy for Stargardt disease yet. Okay. There was one trial a number of years ago. The results have not been released yet. And I think it may pick up again and provide us with some idea whether it works or not. And there's technical difficulties and implementation difficulties with any treatment for any disease, but especially those that try to deliver a large gene like the Stargardt gene to the retina. So that has some challenges. And then there are, I also get questions about stem cells. How about stem cell therapy? Does that work? And we have uh, no evidence that it makes a big difference or any difference whatsoever, although there have been some animal models that have shown some beneficial effects and some very limited uh, evidence in humans, but certainly uh, nothing that is in the clinic yet for patients to take.
Well, I'm glad you brought up clinical trials. Why should individuals with Stargardt or any IRD for that matter consider participating in clinical trials?
When you read or you hear or you say clinical trial or treatment trial, uh, the more important word in treatment trial is not treatment, it's trial. Okay. So you have to know that you're not getting into this study to be treated. You're getting into the study because they're trying something to see if it's going to help broadly. I think patients need to understand very well what they're getting themselves into when they get into a treatment trial. Now, natural history studies also involve quite a bit of effort on the part of the patients. They have to come frequently, they have to take tests. Some of them are not pleasant, uh, etc. But they're contributing to understanding the disease better. Those are the the natural history studies. The treatment trials, they are also so critical. Without them, how do we know if something helps or not? And most, not most, all trials that take place in this country and in Europe and in the great majority of the world, they're regulated to the extent that um, the patient is protected the best they can be. They still involve risks. The patients need to understand what those risks are. And all studies that take place, I'll speak about those in the US because those are the ones that we are mostly dealing with. Uh, they are done under the guidance and under the review of institutional review boards whose role is to protect the patient and also to protect the investigator. And these studies are monitored by data safety and monitoring boards of individuals who make sure that if anything goes wrong, that it's investigated and the trial is stopped. If it's something that's really major, we call those adverse events that happen. And on clinicaltrials.gov, you can read about every study where the results been released. But what happened to these people? Did anything go wrong with them? And was it a result of the actual treatment being tried, or was it that they were going to get it anyway? So those are all the institutions. I think it's critical to continue to have interest and participation in these trials. Managing patients with Stargardt disease or other IRDs becomes better, but patients need to understand what they're getting themselves into and that they're not getting into it. Oh, so maybe I get treated. That should not be the mindset. The mindset is, yes, I want to participate because I want to help.
Yeah, and I think the other thing with IRDs and any rare disease, particular, because we do a bit of work in clinical trials, it's important for individuals to be educated about the decision, but certainly because they're rare conditions, there are so few options to find research participants as opposed to other conditions, and that's another reason it's important for us to continue to
Yes,
talk about that.
and most of these studies with these diseases have include what they call inclusion criteria, which means do you qualify or you don't qualify. And these inclusion criteria would include like your age. Are you old enough? Are you young enough? Would include what your level of vision is. Is it too good to participate and risk something happening to it, or is it too bad to participate? Because then we cannot measure an improvement or a change or stability of the disease that you have. So even that, I can tell from personal experience, there are many more people from my practice who want to and are willing to participate, but who do not qualify, than those who do, number one. And number two, most of these trials, at least the ones that have to do with gene therapy, will only enroll a very small number of patients across the country. So even if there are thousands of people who have a certain disease, a trial may only enroll 12 patients or 16 patients or 8 patients. So we're talking about small number of patients. Uh, Fortunately, I think recruitment into many of these studies has not been very difficult. So we appreciate all the patients who have volunteered to help find cures for their diseases.
But why is genetic testing so important for those with Stargardt or other IRDs, or a potential for Stargardt?
Okay, yeah, I'll answer it just broadly, but it definitely applies quite a bit to Stargardt disease too. Um, Certain phenotypes, ocular phenotypes, we defined phenotype earlier, can be caused by sequence variations in a number of genes, and the end result is the same. You look at the retina, it looks like retinitis pigmentosa, but then what gene is it of the 100 or more genes that can cause retinitis pigmentosa? You want to know. The patients need to know so they know what their gene is. And they can follow it up, they can learn more about it. If something becomes available to treat that particular genetic type of IRD, that they know it's going to be for them. Uh, and For Stargardt disease, there are a couple of other macular dystrophies and retinal dystrophies that can look just like, no, Stargardt disease can look just like them, or they can look just like Stargardt disease. How do we make sure? If you do the genetic testing and you find uh, pathogenic sequence variations, and that's a topic for another discussion. But if if those are found and interpreted appropriately, you have to go back to the interpretation of genetic testing. Not everybody would know how to interpret them. The laboratory where the tests are done would provide an interpretation, which is correct the majority of the time. But that final decision as to whether indeed this is what's causing the patient's problem rests in the hands of the ophthalmic geneticist or the specialist who is taking care of them. They read the lab report, they interpret it, they understand it, and then they know the patient, they know what they have, and they have to reconcile. And there are occasional patients where the lab findings do not correlate with the clinical findings and vice versa. So in those cases, there may still be a question mark about whether it is or it isn't Stargardt disease or another IRD because it doesn't jive 100%.
I'd like to follow up real quick. This is a bit of a philosophical question, but what about individuals, because these are inherited diseases, whose parents have the condition, or one parent has the condition? Um, should they be considered genetic testing? And I know there are a lot of back and forths on that.
Yes, so genetic counselors know how to answer these questions for individual patients very, very well. And there are a number of considerations there. Children, for example, if finding out, for example, what they have is not going to impact immediately their lives as far as availability of treatment or placement for special services and so on, we'd rather defer their testing, especially if they are asymptomatic. If you have a couple who wants to have have another child and they already have one who's affected, then that creates yet another situation to be looked into. So I think these are very individualized decisions that need to be made after discussions with counselors, either physicians who know how to do the counseling and understand this very well, or genetic counselors who are trained to do that and do this day in, day out. Now, having said that, the genetic counselor and the ophthalmologist would also have to be very knowledgeable in the field of inherited retinal diseases. If if you take a genetic counselor who's either very broadly certified or who deals mostly with patients with cancer or with neurological diseases or something, they they are not going to be as good as genetic counselors who deal only or mostly with patients who have inherited retinal diseases. And there are more and more of those. That group is increasing, just like my colleagues who are in the same field, where there's fortunately more of us now than there were. So if you don't have anyone that's immediately next to you or very close to you, in this day and age, you don't have to travel very far to get this type of care.
Yeah. So you mentioned earlier your access to low vision clinic. Could you share a little bit about how do you speak to your patients, their parents, caregivers about living with Stargardt's and continuing to do so with a high quality of life?
But the definition of high quality of life is also variable, and there's a lot of subjectivity there, what people would consider high quality of life. And uh, that's really a very difficult question to answer for me. The aim should be to maximize the use of the vision anyone has. Uh, the impact on one's well-being is so variable, and you probably know that because of the work you do. I certainly see it all the time, and I honestly think that people can do a lot more than they think they can and achieve a lot more and be much more self-fulfilled that they can despite their loss of vision. I often recount the story of this young woman who was born with a condition called Leber congenital amaurosis. She was totally blind, had no vision whatsoever. She was a downhill skier. I mean, that's taking it to an extreme, isn't it? But she did. And I know others who have gone through college and university and have achieved quite a bit. The other fortunate thing for this generation and coming generations is that technology has advanced so much that we have a lot of help for reading, for learning, for communicating, for utilizing our vision as low as it may be. Uh, Nothing replaces human support. Okay? And you may have all of these things and not have a partner or a parent or a sibling or a good friend, and I don't think you're gonna have a good quality of life, or you may not have good quality.
Well, yeah, and I mean, I think we kind of talk about it as really you alluded to this earlier, lessening the impact of the vision condition on whatever it is that the individual is wanting to do with their
Yeah,
life. And
yeah,
that's really the focus. And whether that's certainly I think access to mental health assistance, as we talked about, and low vision support, those are two ways that can do that, but there's
yeah.
so many other factors in anyone's life that contributes to that. So Doctor, before we wrap up here, do you have anything you'd like to add to our discussion to close this up?
No, I want to thank you and Prevent Blindness for all the wonderful work you do, and I'm happy to take questions from anyone who listens to this uh, broadcast at any time. You can find me easily, and just don't hesitate to contact me.
Well, thank you so much. And for anyone looking for information on Stargardt disease, mental wellness and vision, or low vision, feel free to visit our website at preventblindness.org. Thanks again.
Thank you.